Good morning, good afternoon, good morning, good evening, good afternoon, wherever you are. Thank you for watching this YouTube live stream. It's another session of Your Questions Answered Live. My name is Patrik Hutzel from intensivecareathome.com and intensivecarehotline.com. And I'm here to answer all of your questions, intensive care related. And we have viewers from all over the world, so I want to welcome you. And even if you're watching the recording now, even if you're not live on the show, thank you for watching the recording and thank you for your support. So before we dive right in, you may want to find out what makes me qualified to talk about your questions in intensive care. Again, my name is Patrik Hutzel. I'm a critical care nurse by background. I have worked in intensive care / critical care for the last 25 years nearly in 3 different countries. I also have worked as a nurse unit manager for over 5 years in intensive care. I have been consulting and advocating for families in intensive care for the last 10 years as part of my intensivecarehotline.com consulting and advocacy service. And I'm also the founder and managing director of Intensive Care at Home, where we send intensive care nurses into the home to look after long-term ventilated adults and children with tracheostomies, where we provide BIPAP, CPAP ventilation at home, where we look after medically complex adults and children at home instead of intensive care. And we also provide home TPN. So my passion is intensive care and intensive care at home. And just a little bit of housekeeping. If you have any questions, please type the questions into your chat pad. But you're also welcome to dial in live on the show and ask your questions live on the show. I type the phone numbers into the chat pad, and depending on which country you're in, you can just dial the local number and you'll get me live on the show here and we can discuss and answer your questions. So I encourage you to type in your questions into the chat pad. In the meantime, while I'm waiting for your question, let's just start with the first question. And that is a question we had this week. We get a lot of emails and I'll just answer those questions from the emails that we get this week. And I'll just start there to begin with. This is a question that we had this week from John. And John says, my dad won't wake up after being cooled. He has a tracheostomy and cannot give a thumbs up or wiggle his toes, but he will look and blink his eyes when we tell him, blink your eyes 10 times if you can hear us. The MRI is normal, the CT scan is normal, the vital signs are normal. He's trying to breathe above the ventilator. He's just having a tough time giving a thumbs up, but can squeeze his hands. So, John, if you're saying that your dad won't wake up after being cooled, I would imagine that he's had a cardiac arrest. Most patients that go into ICU and are being introduced or induced into a cooling therapy usually have an out-of-hospital cardiac arrest. Now, you haven't shared how many days your dad has been in ICU, and you haven't shared how many days your dad has been in ICU. You haven't shared how long was the quote-unquote downtime while he had the cardiac arrest. How long did it take to get circulation back? But the good news is that if the MRI and CT scan of the brain are normal, then the only thing between your dad waking up and is probably the number of days he was on sedation and on opiates. So a couple of things there. He would have been, while he was in cooling therapy, he would have been induced into a coma, possibly with some propofol and or midazolam, also known as Versed. Probably would have been in an induced coma with some opiates such as fentanyl or morphine, possibly high doses, because cooling therapy can be quite uncomfortable. Temperature can go all the way down to sort of 33, 32 degrees Celsius. which is probably around 93 Fahrenheit or something like that. And sometimes patients don't tolerate that well. And then they are also sometimes having paralyzing agents. So they're also paralyzed on top of the induced coma. And the longer someone is paralyzed, plus the induced coma, the longer it takes for someone to wake up, from my experience. Now, on top of that, if your dad was cool and had a cardiac arrest and there was query hypoxic or anoxic brain injury, which sounds to me like has been ruled out now, but other things that can happen as prophylactic measures, your dad might have had anti-epileptic drugs to prevent seizures, because the risk of seizures happening after cardiac arrest and potential hypoxic brain injury is there, and they might have started him on Keppra or on phenytoin prophylactically, and they have some sedative effects as well. Now, on top of that, you got to think, if your dad had a cardiac arrest, he's very, very sick. He's very, very unwell, which means you got to give him time to wake up. Just because someone is technically coming out of an induced coma doesn't mean they wake up like that at the drop of a hat, not after such a significant event like a cardiac arrest. We all want to speed up the process of waking up in ICU. The reality is that patients are very, very sick and they just sometimes need time. Again, the good news is MRI and CT scan of the brain are normal. That is good. And he's doing some purposeful movements and he's breathing above the ventilator from what you're telling me. So those are all good signs that you should be focusing on. So what are the next steps here? The next steps are, he needs to continue waking up. And, they need to keep stimulating him. They need to keep talking to him. They need to do physical therapy or physiotherapy, movement of body, hands, arms, limbs, and keep encouraging him to wake up. And you haven't shared whether how many days, you haven't shared whether your dad is on a breathing tube with a ventilator or whether he's got a tracheostomy. Either way, whether he's got a breathing tube or tracheostomy, he needs to be weaned off the ventilator and hopefully can be extubated and then move on in his progress to go out of ICU and go on to some rehabilitation, ideally without a tracheostomy. And it sounds to me like that can be achieved, or what you're sharing with me. Most important lesson here, John, is be patient. And I know that's easier said than done, but from your email, there is way more positives than negatives. Many patients that come into intensive care after cardiac arrest have hypoxic brain injury, depending on how long, how much quote unquote downtime there was, how long CPR took, and how long resuscitation took. So, you should have every reason to be optimistic here and get your dad out of ICU without a ventilator, without a tracheostomy, with a functioning brain. That would be my answer to your question here. So let's move on from this question this week. I also had a question, or more a discussion with a client, with a long-standing client of ours who has their father in and out of intensive care for many years, but their father is finally home and they don't want him to go back to intensive care whatsoever. And they've got a few nurses at home. The client is not like an intensive care at home client like we do here in all metropolitan cities in Australia. It's not an intensive care at home client. The client is actually in the US, but he's had a question this week. He said his dad has pleural effusions on both sides. That's been verified by a home x-ray. It's been verified by an ultrasound of the chest. And, they are wondering, does he need to go to hospital? How should they treat the pleural effusions? Clearly, he has difficulties breathing. What should they be doing? And my recommendation to that was that they should be talking to a respiratory physician or to a pulmonologist and see whether the pleural effusions need draining. And they should probably also do an ultrasound of the lungs to see how much volume is there, and so forth. So that's just quickly to throw that in there. Next question is from Doreen, and Doreen writes in. Doreen says, I'm writing because while doing some research about my options for my father, who is in the long-term acute care facility in the US, also known as ventilation weaning facility, and every day he's there, he seems to be regressing and deteriorating. He was transferred from one of the best ICUs in the nation to there about a week ago, which is not a great place at all. The only top place had no beds available, so we had no choice but to put him in a subpar place. I want him home. Is it possible to have him home through your company, even though you're based in Australia? I'm in the United States. Do you work with families here? He was making strides and seemed to be about a week away from being weaned from the ventilator while he was in ICU. But now he's in this other place, which is not an ICU, and doesn't seem to be prepared to wean my dad off the ventilator. They have no machines, do no testing, medication, or even doctors unless called in. I need help. I'm desperate, and my father deserves the best, and he deserves to be home. If it wasn't for a mistake in the first ICU, he went to October the 31st, he would never be in this situation. He went in the hospital because of a UTI, and he is now in a facility on a ventilator with a tracheostomy. It makes no sense. Is there any way your company can educate me on my options and let me know if you provide services here in the United States? Thank you kindly, from Doreen. Thanks, Doreen, for your question. Well, it is now too late, obviously. If you had contacted me at the stage where your dad had a tracheostomy, what are the next steps? I would have advised you not to go to LTAC under any circumstances. And it sounds to me like he was very close of getting off the ventilator while he was in ICU. And that's probably, you should have probably hung out there for another week or two and get him off the ventilator there, rather than sending him to LTAC. But that's neither here or there, because that's not the situation you are in. And all I can say here is put out another word of warning for families in intensive care in the United States. Do not go to LTAC. I've been making plenty of videos about that, and plenty of evidence there that LTACs are not the right place for someone to wean off the ventilator, because simply they don't have the skills, they don't have the knowledge, they don't have the skilled ICU staff that is needed to work with weaning patients off ventilation. And that's verified by, look at the online reviews from LTACs. Look at them, and you will see they have 1-2 star ratings at the most. And again, the email says, going back, they have no machines, do no testing, diagnostics, medication, or even doctors unless they call them in. Patients are going from intensive care on life support, on ventilation and tracheostomy, to a facility without doctors, without diagnostics. If people in a hospital go to a hospital floor without ventilation and tracheostomy, they get the care they need and deserve. And that's clearly not happening in an LTAC in the United States. So in terms of us intensive care at home going to the United States, unfortunately, we're still not there yet. We are working on it. What you can do is you can contact an organization called bayota.com. I know they're providing some home care for some ventilated clients in the home in certain areas in the United States. So have a look at their website, bayota.com, and check them out there. The only other thing that I need to stress is you can't really go home in a situation like that without intensive care nurses 24 hours a day, because you can already see that they're struggling in LTAC. LTAC doesn't have intensive care nurses 24 hours a day. So, you're putting your dad at risk if you are going home without intensive care nurses 24 hours a day. And last but not least, Doreen, if you are, you haven't shared where you are. If you are in New York City, please contact me privately, and I can probably put you onto one of our contacts in New York City. please send me an email to support@intensivecarehotline.com. Or if you're in the US, you can just call me on the number that I typed in here, 415-915-0090, and you can call me and then I can set you up with our contact in New York City. Now, but quickly going back, the other thing you could do, Doreen, is you can see whether your dad can go back into ICU and hopefully they can wean him off the ventilator. They are well equipped to do that. You know, I mean, the number of horror stories that I read out over the years here, the number of clients in the US that I've spoken to over the years that have loved ones in LTAC and are literally begging us to get their loved ones out of LTAC is enormous. It's huge and it's never ending. You know, LTACs from our research has shown that they are designed to save money. They're not designed for clinical need, right? Patients in intensive care in the US get pushed out of ICU very quickly as soon as they have a tracheostomy. It's almost like bait and switch. Families get told, oh, your loved one needs a tracheostomy and a PEG tube, and the families consent to that without doing their research, and next thing they know, the very next day, there's a bed available in LTAC and patients are getting shipped out without families knowing what's happening, and then they find themselves in LTAC realizing what a disastrous area it is. So, Doreen, I hope that helps. Now, again, type in your questions into the chat pad or call me live on the show to get your questions answered here. Calling live on the show, you can get your questions answered here or type them into the chat pad. I also had a question this week from a potential intensive care at home client, how we send nurses into the home, especially for new clients. Would intensive care at home be happy to send nurses, ICU nurses, without training on a particular client? So that's the first part of the question. So this is a question we get all the time from our intensive care at home client. Obviously, this is from a client in Australia. And they're asking, yeah, would you be, when you take us home from ICU, would you be happy to send nurses without training? So here is the answer to that first part of the question. The first part of the question is, yes, we would, because that's how we got started. And, you know, the value proposition of having an intensive care nurse coming into the home versus having intensive care in a hospital, that's exactly what we do. Now, what we need to learn about is obviously the routine and the preferences of a client. But in terms of making a transition possible from ICU to home, that is all we do, you know. Now, what we have done in the past, and this is a suggestion here, we could start with some shifts in the hospital, you know, in ICU, to get to know your preferences, to get to know your routine, to get to know your care. We can do either way, you know. We can start in the hospital and we can also start at home straight away. We've done it many times, but we've done both. So, you know, that is our that is how we work, and we've done it many times successfully. And it's also important that we you know, get to know your preferences, but we can do that either at home or in a hospital. You know, the next question from that client is, if my spouse isn't available and I have no way of communicating, what would the nurse do on shift? Again, I think we are not perfect, but we're pretty well trained on reading on non-verbal cues of our clients, because, you know, we've been doing it for so long. You know, and our staff are pretty cluey in when it comes to reading non-verbal cues, especially in a home care environment. And the next question is, could you still mobilize me getting out of bed if my spouse wasn't at home? And the answer to that is yes, especially assuming you have all the equipment like a hoist, like a wheelchair, commode, and so forth. And the client also says that, I know there are other intensive care at home clients in similar situations, and that those clients don't insist on training in a hospital. How do they manage new nurses? So how do they manage new nurses? Again, we would, generally speaking, send our senior staff to get you home to begin with and work out the routine with you and your spouse. so that we can then pass it on to other team members. We would send team members that have worked with us for quite some time, that are experienced in the transition from ICU to home. I hope that helps. Rosa typed in some questions. Thanks, Rosa, for your questions. Rosa, you're saying, this is the scenario. I'm in the USA. My dad is now in LTAC and he has been there since Christmas. He has a tracheostomy, but he keeps failing the spontaneous breathing trials. LTAC has a 12-step program. My dad is stuck in 6th step. In addition, since the tracheostomy, no other issues, do you think my dad is being rushed? Now they want to send him to a long-term facility. Wow. Also, a week ago, they put in a lateral chest tube to prevent water retention in the lungs. He started on October 29th in ICU, and they discharged him to LTAC on Christmas Day, 25th of December to present. Okay, do I think your dad is rushed? I don't know, because you haven't shared why does your dad have a tracheostomy to begin with, Rosa? Can you share more? Why does your dad have a tracheostomy to begin with? What got him into ICU at the end of October? I argue there are no set timelines to get someone off a ventilator. There are weaning protocols, but if someone can skip steps, for example, why would you go through a 12-step program if someone can potentially skip steps, right? Tell me more, Rosa, about why is your dad in ICU in LTAC now? What got him into ICU in the first place? Why do you think he's failing the spontaneous breathing trials? Tell me more. So his lungs were weak. He was intubated for 14 days and then failed when extubated. Why were his lungs weak, Rosa? Does he have COPD? Does he have asthma? Did he have a pneumonia? Did he have ARDS? Is there something else? Does he have lung cancer, God forbid? Is there something else? Share. If you can, the more you can share with me, Rosa, the better. So I can it's difficult for me to say at the moment, why is he not passing spontaneous breathing trials? Is it lack of mobilization? Yes, COPD. Okay, he's got COPD. Okay, all right. So, okay, if he's got COPD, a lot of COPD patients do struggle getting off the ventilator, and I have seen long weans for COPD patients. So, how old is your dad, Rosa? Can you tell me how old your dad is? And can you tell me whether there's any other significant pre-medical history? While you're doing that, with COPD, Rosa, most patients have a high CO2, also known as carbon dioxide baseline. Okay, so I would imagine that if he's not passing spontaneous breathing trials, it means his CO2 is probably rising and he needs to go back on the ventilator, potentially with high PEEP, high pressure support, high volumes, not quite sure. And your dad is 81 years of age. Now, age is not an obstacle to wean someone off a ventilator, but it can be, I guess, it's easier for someone that's young to be weaned off the ventilator compared to someone who's 81 years of age. But, again, that should not be an obstacle. Yes, and now you're confirming his CO2 raises. Right, okay. So when his CO2 raises, Rosa, is he getting drowsy? Is he getting non-cooperative? Do you know what's happening? Because that's another thing, when his CO2 rises, does he get non-cooperative, for example? Or is he getting drowsy? Is he getting sleepy? It's almost like, 2 steps forward, 1 step back type of thing. That's one question. The next question is he getting mobilized? Is he getting out of bed? Heartbeat goes up. Okay. All right. Is your father, would you say he's depressed because of the situation he's in? Would you say he's in good spirits? Because there's a huge psychological aspect of weaning someone off a ventilator as well. And what I mean by that is, is he getting out of bed regularly? Is he getting physical therapy? I believe part of a good weaning regime is good personal hygiene, i.e., can he have a shower? Does he have regular bed baths? Ideally has a combination of both. You know, do they brush his teeth? Do they do good mouth care? You know, those are all very important aspects. You know, people keep focusing on the ventilator, and whilst that's very important, you know, there is a huge psychological aspect of weaning someone off a ventilator with very good basic nursing care. You know, especially since he's been in hospital since the end of October. That's terrible. Rosa, you're saying I spent all day with him and he was only mobilized 2 times during the day. That's terrible. So basically what you're suggesting is since the 25th of December, he's only been out of bed 2 times. That's madness. He's got a PEG tube. Yeah, sure. That is madness. And you're saying he's probably sad and desperate to speak. Sure. And he can't speak yet. Understood. Can he at least write some sentences? Can he use a letterboard, or can he use a pen and a piece of paper, or maybe even type something into a mobile phone or an iPad? Is there any way of him communicating at all? But coming to the mobilization part, Rosa, from my experience, you can't wean someone off a ventilator without mobilization. It's not going to happen. And he's blind, sure. Okay. And you're making sure he's getting moved around more, and he's blind. Look, I think the blindness should not stopping him from getting mobilized. It shouldn't stop him from weaning off a ventilator. Let me tell you a little bit more about the mobilization part, Rosa. So your dad's been in ICU since the 29th of October, and he would have spent most of his time lying in bed. Picture this. If you're lying in bed all day and you're on a ventilator, the ventilator is doing most of the breathing for you. Your breathing muscles decondition very, very quickly. Okay, deconditioning in ICU is real. The longer someone is in ICU, the longer someone is in an induced coma. The reality of deconditioning hits in pretty quickly, and it can take time for someone to gain the muscle strength back. And basically what you're telling me, Rosa, your dad has not been out of bed since the 29th of October. No wonder he's struggling in coming off the ventilator, you know. And then obviously you're saying he's sad and desperate. I can totally understand that. You know, I've looked after so many patients in ICU that have an inability to get off the ventilator. Of course, they're getting sad, desperate, they're getting depressed, you know, they're losing the will to live. Now imagine they would just start with sitting him in a chair. That would strengthen his muscles. That would strengthen his, I believe it would strengthen his will to live. Imagine you're lying in bed for 3-4 months. That in and of itself would make you depressed, right? A good ICU, a good LTAC will mobilize patients as quickly as they can, right? But we know what LTACs are like. I've done many videos about it, spoken to so many people over the years that have loved ones in LTAC, and the stories we're getting are just horrendous. It sounds to me like here is another story from an LTAC that doesn't do what they're supposed to be doing to wean someone off a ventilator. Now, you've talked about a 12-step program, Rosa. Now, I argue that 12-step process or program doesn't mean anything to me if mobilization is not part of that program every single day. Right? I would like to see the program, and I'd say, well, it's of no consequence, that 12-step program, unless you're mobilizing and you're doing physical therapy every day and you're doing things like I just mentioned before. Has your dad had a shower in those 4 months? You know, and I'm telling you from experience, a good ICU will make sure their patients will have a shower. It's very labor intensive, it's hard work, but that's what improves a patient's recovery, speeds recovery up. They're less depressed. You know, I also think it's about staff satisfaction, because if you do that, as nurses, you will see patients improve and you have more job satisfaction. It's a win-win all around. So, if that 12-step program does not have mobilization as part of it, does not have showering, in it, I'd say all the other steps are almost obsolete. You're saying my dad is not getting mobilized enough, and I don't know if he's had a shower. I will ask today. Yeah, sure. Ask. I argue, Rosa, if he's not getting mobilized, it's unlikely he has a shower. I'm not ruling it out, and I hope he does. But usually, when you mobilize someone, just to illustrate that for you, when you mobilize someone in a chair, then you can mobilize them in a shower chair, and you wheel them to the shower, to the bathroom. Simply as that, So that would be my recommendation. The trouble that you're having in LTAC is most staff are not ICU trained. Most staff don't have enough experience to wean patients off a ventilator. You've already shared that. There's no doctor on site. Who would be overseeing a ventilation wean if a doctor is not on site? Yes, there's probably a respiratory therapist somewhere in the mix. You haven't shared how often a respiratory therapist is coming. But you can see, with patients being critically ill and immobile, muscle wastage is real. Deconditioning is real. Muscle wastage and deconditioning includes the respiratory muscles. And imagine you're sitting up. You need to sit upright. You need to strengthen your upper body. That in and of itself will help improve your breathing muscles. And that way you can start breathe more and more independently. If that makes sense. So Rosa, I don't have a quick fix for you, unfortunately, but I hope that helps in terms of what the next steps are. Now, you are saying my dad is stuck at the 6th step. Do you know what that 6th step is? It would be great if you could share the 12-step program here, because then we could go through it one by one and I can give you my take on things. We could certainly do that. That would be amazing. Now, just give me 1 second. I just need to hydrate my throat. So yes, Rosa, if you wanted to share the 12-step process, that would be helpful. If you have any other information that you think would be valuable to help you with this situation, please type it in the chat pad, or you can also dial in. In the meantime, I'm reading out the next question. Are you saying, I witnessed a trial, he only lasted 30 minutes on his own. So when you witnessed this, Rosa, was your dad in bed, or was your dad sitting out of bed? And then you're saying the ventilator is at 50% with the PEEP 5. Okay. So the question here is this: yes, in bed. Of course, he's failing a weaning trial in bed, or a spontaneous breathing trial in bed, because he has no upper body strength. That's why he's failing the weaning trial. His breathing muscles. So your dad was in ICU. He was immobile. He was deconditioned. He was in an induced coma until he had the trach. So it doesn't take long for the muscles to waste and get deconditioned. And then once he's been to LTAC, that's almost 2 months since he's been admitted to ICU. They should have started mobilizing him in ICU. I am not surprised that he's failing a weaning trial in bed, unfortunately. He needs to get out. The sooner the better. So you are saying that the ventilator is at 50% with the PEEP 5. So if you're saying he's failing spontaneous weaning trials, what that means is they would swap him from a controlled ventilation mode, i.e. SIMV, CMV, and others, or pressure control, where he gets a set rate of breaths delivered by the machine every minute. So let's just say he's on a SIMV mode with 12 breaths per minute, guaranteed delivery from the machine. And let's just say he's breathing 12 breaths and from the machine, and then he's breathing 8 breaths on top of that, a total of 20. So 12 from the machine, he doesn't need to do any work, and then he's breathing another 8 breaths on top of that. And then they reduce the rate of 12 down to 6, for example, and then your dad's respiratory rate goes up because he's not getting enough breaths, right? So then they put him back, and then maybe they do another trial, and then maybe they swap him over to a spontaneous ventilation mode, such as CPAP or pressure support, and that's when he's failing. So, but again, he will continue to fail that unless they start with breathing exercises, unless they start with mobilization, strengthening his breathing muscles. We had 23 breathings from the machine. Sure. Question is, are they 23 breaths per minute guaranteed by the machine, or are there, for example, 20 breaths guaranteed per minute from the machine, and then he's breathing 3 breaths on his own? So the devil is in the detail there. Also, if his ventilator is still at 50% oxygen, it needs to go down to 40% or below. Okay, I hope that helps, Rosa. You know what needs to happen next. 23 by the machine. Okay. Yeah, okay, that's fairly high. And you know why it's high? It's high because he's got a high CO2. One way to get CO2 down is by, breathing faster, right? That's one way to get CO2 down. Not the only way, but it's one way. So that might stand in his way of getting wind of the machine as well, right? So what they might start to begin with is, are they using BIPAP? Are they using BIPAP with that 23 breaths per minute? So the ventilation mode plays a big role. One way to get CO2 down is by using BIPAP. You might need 23 breaths from the machine and needs some BIPAP pressure. I hope I'm not getting too medical here, but that might be a starting point. But I sound like a broken record here, Rosa. He needs to get mobilized. He needs to get a shower. Imagine his quality of life has been so poor. I think that's fair to say. His quality of life has been so poor since the 29th of October. Imagine he's getting mobilized on a day-by-day basis. Imagine they start to shower him. If you're lying in bed for 4 months, your brain is shutting down. So that mobilization part is critical. And you're very welcome, Rosa. Keep asking questions as I'm going along here with other questions that we had this week. I'll just gotta look at my phone and see what other questions we had this week. Just give me 1 second, please. Just give me 1 tick. Where is it? No. There it is. There it is. Sorry, next question. Next question is from Laura. My 5-year-old son is currently in the pediatric ICU. He was diagnosed with enterocolitis, which led to sepsis. He was ventilated on the 29th of December 2022. His blood pressure dropped, and he also required dialysis for his kidney failure. He developed compartment syndrome in his left calf and was operated on. He has been on morphine, fentanyl, and a variety of other drugs. They removed all sedation aside from some morphine and extubated him on the 11th of January. But he's struggling to open his eyes. Is this normal? Wow. I'm sorry, Laura, to hear about your son's situation. Is this normal? Well, with your son having had a compartment syndrome and the enterocolitis, it sounds like he would have needed to be heavily sedated. I would imagine that his compartment syndrome caused him a lot of pain, and therefore they would have given him a fair amount of fentanyl and morphine, and possibly also midazolam or propofol. Then you're also mentioning that he was in kidney failure. So a combination of kidney failure, where it takes longer for sedation and opiates to be washed out of the body, and with him having had compartment syndrome and where he needs to be pain managed to a degree, I'm not surprised that he takes his time waking up. So what you need, again, easier said than done. You need to be patient here. You know, there's no indication from what I understand that your son has any brain damage, you know, even though if he's not waking up, they probably should be looking at doing a CT of the brain, doing an MRI scan of the brain to rule out any brain damage, stroke, God forbid. You know, that would be one of the next steps. Other things, keep coming back to what I said a minute ago, other things are things like mobilization, physiotherapy, physical therapy, you know, stimulating, maybe read him out children's books, maybe play his favorite music, you know, movie, you know, keep stimulating him, keep talking to him. And I'm sure that in due course, assuming there is no brain injury, he will wake up. So just be patient here. Again, like with many adults as well, it can take time to wake up. Your son has been very critically ill, and he might just need time to recover, and he might just be just simply not ready to wake up, irrespective. We all want to speed up waking up, of course, but he might just simply need time. Okay, let's get on to the next question before we wrap this up for today. Oh, can't read this, I can't zoom in. So my daughter keeps getting MRSA in her tracheostomy since they put it in at the hospital yesterday. I told them that to start her on home heavy antibiotics, and she was swollen, so to give her liquid Lasix because she was holding fluids around her lungs. They told me that the pneumonia today, the x-ray looks 80% better. I want to bring her home. She's giving up in there. What do I do? Right, okay. A lot of patients in, and that is from, can't read, it's too small. Anyway, so a lot of patients in ICU get MRSA. Now, MRSA is not necessarily something that's deadly. It's definitely concerning, but you know, she might just need antibiotics and actually go home. Now, you haven't shared your location, but you know, if you're in Australia, you should contact us for intensive care at home, and then we'll help you take your daughter home. If the pneumonia is improving, that is really good, you know, and once the pneumonia is cleared, we can take her home. You know, there's no issue there, but you have other questions there as well. They started her back on the ventilator yesterday with the tracheostomy because she has low oxygen saturations from the fluids in the lungs. Yes, and you mentioned potentially giving Lasix. Yes, giving Lasix to get rid of the fluids on the lungs, but it could be as simple as suctioning her. It could be as simple as putting her on a fluid restriction. Those could be the next steps, or would be the next steps. You said she was supposed to have a swallow test, but she can't now because she's back on the ventilator. I was hoping she could get the tracheostomy out. And she, if you had a nasogastric tube, but she has a PEG tube. Right, okay, it's a bit, the question is not quite clear to me, but what you can definitely do is, the MRSA happens unfortunately in ICU. It's probably something that's concerning, but it's another sign that she probably should go home, because there's no MRSA at home. MRSA is a hospital-specific infection, and we don't have that with our clients at home, with intensive care at home. So the best next step for you really is to get your daughter home. And again, if you are in Australia, you should contact us at intensivecareathome.com with one of the numbers on the top of our website, and we'll help you in taking the next step to take her home, and also help the hospital to manage that bed block. We can give Lasix at home. We can manage many things at home, including home X-ray now. So, okay. Now, next question is from Lauren. Lauren says, "Hi Patrik, my newborn just got diagnosed with chronic lung disease, and she is on a CPAP ventilator. She now has low lung reserve. Her lungs are too small for her body, and also she has been on high flow. They now tell me she will be on CPAP for life. Can I ever take her home on a CPAP ventilator to make life comfortable for her? She's so used to the CPAP because of the hospital not trying to wean her. Please help." Oh, absolutely. This is a great question for intensive care at home, because we've had many newborns at home, premature babies that went home with a tracheostomy on CPAP, but also went home without a tracheostomy on CPAP. And some of them actually got weaned off the tracheostomy and the CPAP, or some of them got weaned off the CPAP. Now, why did those kids need CPAP or tracheostomy? Yes, they were premature babies. Their lungs weren't developed to the point where they could breathe independently, but that comes back over time from what we've learned with those kids at home. So really, you should contact us at Intensive Care at Home. I can see that you are in Australia from your email, and you should contact us. We can definitely help you taking your loved one home. The NDIS funding will most likely fund nursing care, and you should absolutely contact us. This is right up our alley. This is bread and butter for us. We have helped many toddlers to go home on a ventilator with a tracheostomy and actually help them wean off at home. Please contact us. I hope that answers your question here, Laura. And then I've got one more question to go before I wrap this up today. If you have any other questions, please type them into the chat pad while I'm reading out my last question here. And then I'm going to wrap this up for today. This is an email from Ashley. Ashley says, "I just wanted to start by thanking you. You have been an absolute invaluable resource for me over the past 2 months. My sister, who's 35, had a cardiac arrest at home on Thanksgiving Day. She spent 6 weeks in ICU and is now left with pulmonary issues. She can't be weaned off the ventilator. Much of this time has felt like the doctors and the hospital are the enemy due to me not agreeing with much of their," she puts that in quotes, "treatment. At one point she was on 20 different medications. Almost every time I needed information, I would find an email from you that said exactly what I was needing at the time. I want to thank you for that. If I may ask one question. She's on a tracheostomy but doesn't need ventilation anymore. It's very apparent to me she doesn't like the tracheostomy. She fought the ventilator the whole time. She keeps having coughing fits to the point they give her morphine. My question is, can they get rid of the tracheostomy and use non-invasive oxygen if and when needed?" Technically, she's vegetative, and again, Ashley puts the term vegetative in quotes, according to her doctors, but I disagree. She is minimally conscious and is aware of what's going on. She can breathe on her own as long as the sadists don't load her with opiates, and can cough very well. Once again, thank you for what you're doing. You are an angel for sure. From Ashley. Okay. Right. Where do we start? It's great that she doesn't need ventilation anymore. That's fantastic. And she doesn't like the tracheostomy. Well, can she have the tracheostomy removed? Well, quite simple. She can have the tracheostomy removed if she can cough, if she can swallow, if she can protect her own airway. Those are the three main ingredients to have the tracheostomy removed. Again, let me repeat: cough, swallow, and protect her own airway. If she can talk, if she can speak with a speaking valve, that's definitely a benefit. Those are the things that should be happening as a next step. Now, as far as the morphine is confirmed, she's having coughing fits. Look, I don't know what that looks like. Does that mean they need to give her morphine to get her to stop coughing? I don't know. Hard to say from a distance. Bear in mind, morphine has as a side effect respiratory depression, i.e., if she's breathing spontaneously, the morphine may inhibit that. They should use the morphine very, very lightly. The question is, why is she having the coughing fits? Is the tracheostomy very irritable? Does she need a different size tracheostomy? Right? Is the tip of the tracheostomy leaning on to the tracheal wall and is causing coughing fits? Do they need to shorten the tracheostomy, for example? Best way forward is to remove it, of course. But again, if she's not fully awake, if her Glasgow Coma scale is minimized, she may not be able to protect her airway. She may not be able to swallow. I don't know. You didn't share any of that in this video, in this email. And you are saying she's minimally conscious and is aware of what's going on. The question here is she conscious of what's going on to the point where she can cooperate without a tracheostomy? Another question is, how often does she need suctioning? Once a day, once an hour, once every half an hour? Those are all questions you need to ask. If she does need suction frequently, can she clear her airway without suctioning? So, and can they use something else to suppress the coughing fits? Again, do they need to use medication, or is it as simple as changing the size of the tracheostomy? And is it as simple as looking at whether the tip of the tracheostomy is sitting at the end of the tracheal wall and is irritating the trachea, and therefore she coughs? We've had clients like this before, or I've seen patients in ICU, whether at home or in a hospital, where the tip of the tracheostomy needs to be cut by a couple of inches or by a couple of centimeters. So I hope that helps, Ashley. So I'm going to wrap this up for today. We've been going for nearly an hour. If you have any other questions, please type them in. If not, I am going to wrap this up in a minute. Thank you so much for coming onto the call and for sending in your questions this week, but also thank you, Rosa, for participating live here and for your questions. I will do another YouTube live next week, same time, Sunday morning, Melbourne, Sydney time, 10:30 a.m., which is Eastern Standard Time in the US, 6:30 p.m. on a Saturday, which is 3:30 p.m. Pacific time. And I look forward to seeing you then. Now, if you have a loved one in intensive care, adult or child, and you want to go home, especially if you are in Australia, you should contact us. We can help get you home from intensive care, especially if you're long-term ventilated with a tracheostomy and ventilator. Or if you need home TPN, if you need BIPAP, CPAP at home, if you need seizure management at home, we can do all of that with intensive care at home. Please contact us at intensivecareathome.com. Contact us on one of the numbers on the top of our website, or send us an email to info@intensivecareathome.com. And if you have a loved one in intensive care and you need help just with questions answered, with consulting advocacy, please go to intensivecarehotline.com, call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com. Also, if you need a medical record review, we can help you with that as well. We review medical records for clients in intensive care or after intensive care. With intensive care at home, we are also now providing specialist support coordination for our clients. So if you're looking for a specialist support coordinator for intensive care at home, especially if you have a loved one in intensive care, please contact us as well. Also, have a look at our membership for families in intensive care at intensivecaresupport.org. There you have access to me and my team 24 hours a day in a membership area and via email, and we answer all questions intensive care and intensive care at home related. Now, if you like the video, give it a thumbs up, subscribe to my YouTube channel for regular updates for families in intensive care, and share the video with your friends and families. Click the notification bell and comment below what you want to see next, what other questions and insights you have. I'll see you during the week with my quick tip videos, and I'll see you again next week with another YouTube Live Your Questions Answered. Thanks everyone. Take care for now, and I wish you and your families all the very best.